All of the doctor and patient testimonials in this program are real and unrehearsed. No one was compensated in any way for his or her statements or appearance in this video. Back pain is the #1 complaint in North America, affecting 80% of us at one time or another. The impact is devastating, with no real, long-lasting relief. Until now. For the first time, low back patients can achieve long-lasting pain relief with IDD Therapy, available only through treatment with a revolutionary spinal system. No surgery, no injections.
We are experiencing very, very good benefits with the machine.
Well, we've had good success. I'm enthused about the results.
We know without a doubt it gets people better.
Yes, they get back to work, they get back to play much sooner.
Our average patient has a 96% reduction in their pain. Every single one of our patients does better. I've never had a complaint.
IDD, internal disc decompression therapy, is a proven, innovative treatment for the relief and healing of low back syndromes, including herniated or bulging discs, degenerative disc disease, posterior facet syndrome, sciatica, and other low back conditions. With an up to 86% success rate, thousands of patients have experienced dramatic pain relief and healing. IDD therapy is non-surgical, non-invasive, and typically does not involve pain medications. The treatment is not only safe and painless, but also comfortable and relaxing. Treatment includes approximately 15 treatment sessions and is completed in less than 30 days. Each procedure is performed with a patented spina system, an intervertebral decompression device by a certified spina clinician. The treatment sessions are brief, lasting between 25 and 30 minutes.
I have an insight into it that a lot of people don't have, because we've been treating back injuries aggressively since the late 80s. The problems that this device is intended to treat, and in fact that it treats best, are located in the lower part of the spine called the lumbar spine, usually 5 vertebral bodies, sometimes 4, sometimes 6, depending on the radiologist and the patient. And we're going to focus in on the lumbar spine with this little guy here. Now this is again a picture of the lumbar. It's a plastic replica of a lumbar spine with some nerve roots attached and some sympathetic chain action over here. The nice thing about this model, we can open it up and we can look at the discs from the inside, and we can see these discs, the little shock absorbers that keep the bones apart, are normally quite healthy, and they are between the bones, and they have an inner and outer portion, and they can become bulged or herniated out, and these are depictions of certain types of pathology. The important thing about the discs is that they separate the vertebral bodies, they give height to the vertebral bodies, and they form the correct boundaries of the spinal canal to protect the very important blood vessels and wires that keep our bodies running the way they should and out of pain. What the decompressive treatment does, several things. One of the most important is create a negative pressure inside the disc, which brings more, by simple hydrostatic pressure, brings more nutrients flowing into the disc. And that gives the disc more nutrition, more oxygen. So we believe that helps the nutritional status of the disc. We can couple an anti-inflammatory medical treatment with the decompression of the offending disc segment, and this works whether it's a straight disc herniation, or in some cases there's even a relative spinal stenosis caused by the disc bulge. And any of those things, we believe, as long as it's caused by an injury or damage to the disc, can be helped by decompression of the disc segment.
IDD therapy is the application of specific decompression protocols designed for spinal pathologies, which can only be treated using the spina system. These protocols can reduce pressure on the vertebral joints, promote retraction of herniated discs, promote self-healing and rehabilitation of damaged discs, thereby relieving low back pain.
Say you have a disc herniation where this model shows it at L3-4. Not a slightly atypical location, but say you're trying to go here or higher in the lumbar spine, which we do treat. Let's take, for example, we have, say this is the disc in question, and we want to decompress this space. So, multiple choice question. Would we want to perform the decompression by taking an axial force like this, straight up, or would we rather bend it like this or bend it like that? The answer, of course, is we'd probably rather do it as straight as we can. Since the lumbar spine is curved, it's hard to do that if you pull at the same angle. So the current decompressive therapy can target an individual segment. And so say the segment is L5-S1, you really want to be pulling L5-S1 straight apart. You don't want to be pulling it like this. So the way the machine is set up, and it's complicated to discuss without the machine, but basically by adjusting the angle of the pull, which can be done rather precisely, we can target or put the maximum force at a given segmental level, which accomplishes a segmental distraction, which before this device was really impossible to achieve. So every patient requires, we believe, a medical evaluation, not just to see where the discs don't look good on the MRI, but where the patient's problems are, and trying to put everything together and decide what the cause of the patient's clinical problem really is. And once we have an idea where that is, what nerve level and what disc level, we can target the treatment to maximally affect that segment. And so we treat patients very differently, and we have patients that have had a disc bulge at 1, 2, 2, 3, but also 4, 5, 5, 1. So we try to treat 4, 5, and 5, 1. And we have many patients that have gotten better like that and come back with some more problem that after further studies we think is referable to a higher level. They can be retreated but with a different angle. These are of course the more complex patients, and you can find that then you get improvement at that level. So it does work. It's not perfect, it's not 100%, but the ability to target a given segment is really one of the very strong points of this treatment, as opposed to the older treatments, which really would just kind of stretch the whole spine in every patient the same way, independent of where the pathology was, which we think is one of the reasons that the results are better.
It seems to work in a variety of conditions, a variety of problems in the back, such as disc protrusions, degenerative disc problems, what's referred to as spinal stenosis, where there's thickening of the bones and ligaments exerting pressure on nerves. It seems to be effective in some cases where surgery's been performed on one or more occasions. And the reason it works, I think, is it's actually influence several parts of the back, not only the discs, but the capsules around the joints and the ligaments in a decompressing, stretching fashion. I just think it improves not only the anatomy, but the function of various structures in the back.
I think the most attractive part of this treatment is that it's non-invasive, and people don't have to take off work for months to recuperate from the treatment, and that is a big plus, especially to working families who need that paycheck rolling in every week.
So the sciatic nerve is the big nerve that runs down the back of the leg, comes out behind the butt, goes down the leg, and it's made up of many lumbar nerve roots with some sacral involvement as well. And if that and sciatica could be due to anything, damaging that nerve or bothering that nerve, or causing inflammation in that nerve. But sometimes, and more often than not, we find that there's some kind of irritation much more proximally up in the nerve root. And to understand that better, this model shows how the nerve roots form here in the lumbar region and coalesce to form the sciatic nerve, and there's anterior and posterior portions which are beyond the ability of this poor model to show us, but we're all familiar with them. To illustrate this a little better, we're going to kind of jump in and look at what happens with the disc coming off these nerves, coming off the spine. We're going to go to a slightly different model, an enlarged model. And I'll ask you to give me some artistic license, because this is really, as the neurologists in the audience already know, part of the mid to lower cervical spinal cord, which is up in the neck and not the back. But the important things are that the nerve roots that come out here formed by these rootlets. There's the anterior portion, which subserves motor, and the posterior portion, which subserves sensory. And these things are all grouped together in the exiting nerve root. If there's an irritation of this nerve root here, well, damage here, anywhere up here, or anywhere in the nerve root here, it can radiate in the distribution of the nerve. And the nerves that come out at L4, L5, S1, and S2, and maybe higher, all these fibers gather together to form these big nerves that run down the back of the leg, the main nerve of the leg, which is the sciatic nerve. So any kind of pain that radiates down the leg, patients commonly call sciatica. That's because of a sciatic type pain. And again, it's a very common term, and I think almost everybody knows what it is, so we use it. But generally, again, if the involvement was in the nerve itself, we would have a much different treatment. But if the involvement is in the proximal part of the nerve, which we can easily see with our exam and tests, there are many things that could be bothering the nerve close into the spine, but in many patients there's damage or irritation caused by chemical and physical factors, and the physical factors are often damage from a disc which is herniated or bulged or protruded or damaged in some way, what have you, with attendant inflammation. The inflammation can easily be conquered with various medications, either injected or taken orally. And that leaves a structural problem, which remains to cause more irritation and more problems. And for the structural problem, the only way to improve it in the past, and we're talking again about a disc protrusion or a disc herniation being the structural problem, the only way to really improve that was to send the patient to surgery or to give them enough anti-inflammatories that they try to heal it up. And in many cases, in some cases where there's a disc injury or irritation behind that, we think the problem is very amenable to decompressive therapy in the lumbar spine. And this can be helped by decompression. The decompression idea is to suck more fluids in here, build up the disc height, try to improve the hydration of the disc, and try to decrease the actual physical herniation. Again, the MRI isn't everything. We have to remember that the patients don't come to us because of an abnormal MRI. They come to us because something is wrong with them. And we know that the decompression therapy helps many of those patients get rid of what is wrong with them, or at least makes them better. So again, disc damage, disc herniation or protrusion, bothering the nerve, two aspects, chemical and physical. Physical helped by decompressive therapy, and this nerve, of course, can go anywhere the nerve is going in the body. And if the nerve is in the lumbar region, especially the lower lumbar upper sacral region, they coalesce to form the sciatic nerve, which is the big nerve. And whenever people have severe pain in the back, going down the back of the leg, going down the buttock, back of the leg, side of the leg, into the lower leg or foot, it's almost always carried in this nerve, at least part of it.
IDD therapy is a medical protocol that has been evolving since the inception of decompression devices in 1989. Through extensive study, the various practices that were determined to yield the best results were compiled into a set of standards for the delivery of decompression therapy. The technological component of IDD therapy began with the advent of the DRS system, developed by Carlos Becerra in 1996. Since that time, the machine and computer software have evolved to new levels. Advanced programming allows much smoother and more precise treatment delivery.
This is a very good MRI showing some problems. This patient's a 51-year-old man, 52 actually at the time of this shooting. And what we see here, the patient is a president of a hospital in Philadelphia who comes here with 1.5 years of back pain. Okay, it's a nice fluffy disc, 52-year-old guy, and we can see again the bones on either side. We can see an intact end plate. We can see the annulus fibrosis. We can see a nice dark tire appearance with the fluffy nucleus pulposus in the center. And this is really beautiful. Some people would argue a slight bulge, but we think that's really pretty normal. This is really a pretty nice disc. And this is normal, and it's just fine for a 52-year-old guy. We look up here, we see L2, L3, and we see that's also quite normal, really, really fine. You see good disc hydration, good disc height. As we go down, these disc spaces should get bigger and bigger, and we see here's the problem. This is L3, 4, which we know he injured about 1 year or so before we saw him, 1.5 years. He had physical therapy for 9 months. We explained to him that we thought this was the acute disc injury, and we took this MRI and we saw the disc injury at 3-4, which was similar to an MRI he'd had about a year ago, perhaps a little more degeneration here. And for various reasons, including his symptoms and electrodiagnostic studies, we were pretty sure this was the bad boy. This was the disc that was hurting him. Now, this is part of where the differential diagnosis comes into play, because you see on the MRI, there's 2 bad discs. There's 3-4 and 5-1 with 2 beautiful ones, and actually the ones higher up were normal also. So which one is really bothering the patient? And that's where you have to be a doctor. And as you see, the angles are somewhat different. The angle of distraction for 5-1 is different than it would be for 3-4. He had 11 treatments with us. We recommended 20 for a disc like that, but he had 11 treatments, and he was done. He felt better. He didn't feel it was worth driving here anymore. We were fortunate enough to persuade him to have one more MRI done after the treatment. This was done February 2nd of 2000. The next MRI was done March 10th, so it's about 5-6 weeks later in 2000. What we can see is, first of all, look at the bad discs. The bad discs, the ones that we thought had lost some disc height, were bulged or protruded or herniated out a little bit, and had also lost signal, showing that they were damaged, they were starting to dehydrate. The bad disc had actually improved in hydration status because of increased signal in T2 weighted sequences. The bulge or herniation posteriorly was actually much less, which was very nice. The disc height had improved. What we do is enlarge the films, and you can measure with a micrometer the disc height at various levels, and you see he actually did have significant increase in disc height, looking at it in percentage of the vertebral body that's adjacent to it. So here we have improvement in the disc height, improvement in the herniation, and we think, just as importantly, improvement in the hydration status of the disc. Now the fun begins, and this is why we did the